There are a number of different properties of blood itself and of blood vessels that can both impact how efficiently that blood moves through the body. And that's the topic of this portion of our lecture on blood vessels. We're going to be looking at things like peripheral resistance and blood pressure and the impact of those on blood flow. So first, let me just tell you a little bit about what blood flow is, and then we'll talk about the kinds of things that can impact blood flow. All blood flow is basically the amount of force that blood is being pushed at, and you can think of that like the pressure gradient, divided by the amount of resistance that blood is encountering. Another way of saying that is you can determine how fast blood is going to flow by looking at the pressure at which it's being squeezed out of the heart at and dividing that by how much friction it's encountering as it tries to move through the blood vessels. Now, obviously, blood flow is really important because without blood flow to tissues, those tissues can end up dying, which is a process called necrosis. And if enough areas of the body go without blood flow, you can actually end up with death of the organism. So blood flow is principally very important. Now, we can impact blood flow a number of different ways. You can have different viscosities of the blood. In other words, if the blood gets thicker, such as in polycythemia, where you have an increased count of red blood cells, the thicker blood is, the more friction it's going to generate as it moves through the blood vessels, and that's going to reduce blood flow. You can also impact blood flow by the pressure at which the blood is squirted out of the heart. And you can impact blood flow by something called vascular resistance. Vascular resistance is the amount of friction that blood cells encounter as they move through blood vessels. You can imagine that if I'm a blood cell here, red isn't a good choice. How about black? If I'm a blood cell right here, if the second I bump up against the interior wall or the endothelium of a blood cell, I've encountered friction. And that is, by definition, what vascular resistance is. There's a related term to vascular resistance called peripheral resistance. Peripheral resistance is the sum total of all of the vascular resistance in the systemic circuit. So if we totaled up the total amount of friction that blood encounters as it moves through the systemic circuit, we would have what's called peripheral resistance. Now, we're going to look into more detail with this whole idea of resistance, etc., in a little bit. First, I'm going to focus on blood pressure, though. Blood pressure, which I said is one of the things that can impact blood flow, as you know, can be measured with a blood pressure cuff or what's called a sphygmomanometer. And hopefully you'll get to play around with sphygmomanometers in one of your physiology labs, and you'll have a chance to see how they work and how you can use one to measure systolic and diastolic pressures. So let's look a little closer at blood pressure. And this graph here that you're looking at is going to show you how blood pressures change over the course of the systemic pathway. So imagine you're a blood cell and you have just been ejected out of the left ventricle. The first place you go is into the aorta, and you can see that the aorta experiences very high pressures, but it also experiences a very great range of pressures, and that's because when the ventricle contracts, the aorta experiences a high pressure of blood moving into it very rapidly, but then when the ventricle relaxes, when it's in diastole, pressure drops considerably. And so we have a large range or window here in which blood pressures vary. Now remember, again, I told you that the aorta and some of the other larger elastic arteries have this ability to stretch and recoil as blood moves in them, so that when blood enters at high pressure, the aorta and other large elastic arteries will expand to sort of absorb that high pressure, and then when pressure drops off during ventricular diastole, those blood vessels will recoil, and that will help to reduce how much drop in pressure they're experiencing. Over time, as I said before, those elastic arteries help to even out the blood flow so that where we have a very large discrepancy in blood pressure in the aorta, by the time we get down to the arterioles, that difference between systolic and diastolic pressure is almost completely vanished. And again, as I've said before, that's really critical because when we enter capillaries, they are only a single cell layer thick. And if we had all of these fluctuations in blood pressure, it would very likely damage those capillaries, shred them, rip them open, and obviously they would no longer be functional at that point. So again, blood pressure is just the force of the blood moving against the, pushing up against the endothelium, the interior wall of a blood vessel. Remember again, as I talked about previously, there are pressure gradients involved in things like the systemic circuit where we have the highest pressure located with the aorta and the lowest pressure associated out here at the vena cava, and that difference between high pressure and low pressure assists or facilitates the movement of the blood through the systemic circuit. We can vary blood pressure, though. We can impact it a number of different ways. Obviously, the biggest way is by influencing the behavior of the heart. Either we influence its contractility. We can also indirectly influence it by raising or lowering heart rate. So we measure blood pressure, as we said before, using measuring both the systolic and the diastolic values. Then we do that using the sphygmomanometer. And with those two values, we can calculate something called pulse pressure, which is the difference between the systolic and diastolic values. Why do we care about calculating pulse pressure? Well, because pulse pressure is needed in order to calculate what the mean arterial pressure is. And what mean arterial pressure is basically the average blood pressure experienced in a blood vessel over the entire course of the cardiac cycle. And that's inclusive of both diastole and systole. So we're trying to get sort of an average effect. That average or mean arterial pressure is calculated by taking the diastolic value from the blood pressure reading and adding 1/3 of the pulse pressure value. There's a second way you can calculate mean arterial pressure, which is to take the cardiac output and multiply it by the resistance in the blood vessels. So since I keep talking about resistance, it might be a good idea for us to look a little bit more at things like peripheral resistance and the interrelationship of resistance with blood pressure. Now remember I said by definition that blood pressure is the force of erythrocytes pushing against the endothelium, the interior surface of a blood vessel. So it should make sense to you that if I alter the shape of the blood vessel, if I constrict the size of the diameter, or if I dilate the diameter and make it larger, that's going to impact how many red blood cells are actually coming into contact with the endothelium, with this internal wall. The more red blood cells I have encountering or rubbing up against the interior wall, the greater the resistance is going to be and the greater the pressure is going to be. The fewer red blood cells I have bumping up against the wall, the lower the resistance and the lower the blood pressure. So what I'm telling you by that is that blood pressure is and resistance are basically moving in sync together. If resistance increases, blood pressure increases. If resistance decreases, such as in vasoconstriction, then blood pressure is also going to decrease. Okay, so we can alter blood pressure by altering the peripheral resistance. The main blood vessels that do all of this altering of peripheral resistance are the arterioles. And that's for two reasons. One, remember arterioles have a good amount of smooth muscle tissue present, so they're pretty vasodynamic. The other reason is there are more arterioles present in the body than there are any other type of artery. Okay, you only have one aorta. You only have, a few dozen conducting arteries, but you have thousands of arterioles. And imagine if all of them are dilating together or all of them are constricting together. This can have a profound effect on peripheral resistance. So Vasoconstriction, as we said before, can lead to an increase in blood pressure. There's a number of ways we can induce vasoconstriction. The one you're probably most familiar with is if the sympathetic nervous system secretes norepinephrine and epinephrine. Those have the effect of causing vasoconstriction systemic wide, and particularly in arterioles. On the other side of the spectrum, if we dilate the blood vessels, such as up here, what we're doing is we're reducing peripheral resistance. And when we reduce peripheral resistance, blood pressure will also drop. So examples of this would be if the parasympathetic nervous system influences behavior of the blood vessels. Now, one other thing I want to mention is this first line up here, that we can impact blood pressure not only by altering the diameter of a blood vessel, we can also change blood pressure by tweaking activity with the heart, as I mentioned before. I can increase the heart rate. I could increase the stroke volume. Okay, and both of those are going to influence cardiac output. And as we saw in the previous slide, we know that mean arterial pressure is a function of cardiac output and the amount of resistance. So we can alter blood pressure by altering heart activity. We can alter blood pressure by changing arterial activity, or we can change both arterial activity and heart activity, and this will impact blood pressure as a whole. Now, one other thing I want to say about resistance before, oh, actually, you know what? I think I have another slide for it, so I'm going to hold off on that. It's coming up. So let's go ahead and move on here and talk about how blood pressure is regulated before we go to talking more about resistance. So blood pressure regulation is one of those homeostatic set points that you remember when we learned about homeostasis and negative feedback at the beginning of 201. Regulation of blood pressure is very important. If blood pressure, for example, is allowed to remain high for too long a period of time, that puts a lot of stress on capillaries. And those capillaries may begin to tear over time. And once we damage those capillaries, they don't grow back. What grows back in its place is scar tissue, and that drastically impacts the ability of capillaries to do their job of moving oxygen and carbon dioxide and nutrients and metabolic waste products, etc. So we can regulate blood pressure in a number of different ways. One way we can regulate blood pressure is by tweaking the volume of blood we have. Generally speaking, the higher the blood volume, the higher the blood pressure, and that's because the more volume of blood I have, the more blood then that's coming in contact with the interior walls of the blood vessels. So I'm going to have greater resistance experienced. The lower the blood volume, obviously, the lower the blood pressure. Okay. Hormones can also can come into play here with altering blood pressure, and they can do that either directly or indirectly. For example, aldosterone, an antidiuretic hormone, which you learned about when we were looking at the endocrine system, both have the ability to influence kidney behavior, and they either directly or indirectly get the kidney to retain water. And the more water I retain, the higher the blood volume will be. And as a result, as we know, higher blood volume means higher blood pressure. Angiotensin II is another example of a hormone that can impact blood pressure, but rather than impacting it by first impacting volume, angiotensin II impacts blood pressure by changing resistance. And here's how it works. In your kidneys, there is a collection of cells we're going to learn about in a couple weeks whose responsibility it is to monitor blood pressure in the kidneys. And if they notice, for example, that pressure in the kidneys is dropping, they will begin to secrete a hormone called renin. That renin enters into the blood and it interacts with a precursor molecule called angiotensinogen. And when renin encounters angiotensinogen, it alters the angiotensinogen by cutting it up. And when it cuts it up, it creates an active form of a hormone called angiotensin I. That angiotensin I in the blood then circulates to the lungs, And there's a converting enzyme in the lungs called angiotensin converting enzyme, ACE, which converts angiotensin 1 to its final active form, angiotensin 2. Angiotensin 2 then has the ability to stimulate constriction. Okay, it stimulates the constriction or vasoconstriction of blood vessels. You can kind of tell that actually by the name. Tensin means to tense up, to contract. Angio relates to blood vessels. So angiotensin 2 literally causes blood vessels to constrict, and that causes the diameter of blood vessels to be smaller, therefore blood pressure goes up. Another hormone that can impact blood pressure is atrial natriuretic peptide. This is a hormone that is a polypeptide chain. It is manufactured in the atrium of the heart. And when atrial natriuretic peptide is released, it's because there is too high of a blood volume. This happens, in other words, when blood pressure is high, we release atrial natriuretic peptide, and that helps to lower the overall blood volume by getting the kidneys to secrete more sodium. Okay, and where sodium goes, if sodium is going into the forming urine, water will follow. So we get this secretion of water into the forming urine, blood volume drops, and as a result, blood pressure will drop. Okay, as promised, I'm going to talk a little bit more about vascular resistance. I need to pull a little bit of math into our discussion here. If we're going to look at vascular resistance, and we're looking at a cross-section of a blood vessel, there is a mathematic formula that more or less kind of describes in general how resistance relates to the diameter of a blood vessel. And it goes something like this. I'm going to use capital R for resistance. And resistance is proportional to 1 over R to the 4th. R is the radius, of course. Okay, so if we take the 4th power of the radius and do 1 over the 4th power of the radius, that gives us, roughly speaking, what the amount of resistance is that we would be experiencing. This should make sense to you. I can say this in non-math terms. If you think about, for example, if you've ever gone snorkeling before, and you put on your snorkel mask and the little snorkel tube, and the snorkel tube is maybe, I don't know, 25 centimeters long or something like that. It's pretty easy for you to blow air out of that tube, right? But if the tube were to get really small in diameter, if we made it a straw instead that you had to breathe in and out of, you would have to do a lot more work to push air in and out of that straw as opposed to pushing air in and out of a snorkel tube. So this is basically saying the same thing. Look, if we make the diameter smaller, the resistance is going to increase. If we make the diameter larger, it's going to be much more easy for things to move through that diameter. Okay? And again, that's because when things have a larger diameter, there's less, for example, blood or air molecules or whatever it might be, rubbing up against the wall of the tube. Now, on another note, we can also impact vascular resistance based on the length of a blood vessel. And I'll go back to my snorkeling example again. Okay, let's say you have your snorkeling tube is 25 centimeters long. It allows you to have your head just below the surface, and you can kind of cruise around with your little flippers and look at the sponges and the fish. Imagine instead if I gave you a snorkeling tube that was 3 meters long. Well, suddenly it becomes very difficult to move air. Can you imagine blowing air in and out of a tube that's basically the equivalent of almost 10 feet long? That would be much more difficult than moving air in and out of a short little tube 25 centimeters long. So again, length can impact vascular resistance as well. Now, if you think about it, we as adults, for the most part, the length of our blood vessel beds really don't change all that much. Maybe when you're a little kid and you're going through your growth spurt and you're adding lots more blood vessels and your whole body is increasing in size, well, then you do have a change in resistance that's noticeable because you're lengthening the blood vessel beds. But as adults, we really don't have much of a change in blood vessel length, with the exception of people who become obese. And the reason for that is the more adipose tissue you have, the more blood vessels your body will construct to lead to that adipose tissue. Adipose tissue is highly vascularized, and that is so that we can mobilize lipids very rapidly into the blood when they're needed. So the more adipose tissue you add to your body, the more blood vessels you add, the greater the vascular length, and the more your heart has to work to force that blood through that longer vascular bed. So again, what are some of the contributors to vascular resistance in your body? I've talked about some of them already, but it's always good to summarize them again. Remember, we said how viscous your blood is can impact resistance. The thicker your blood is, the more resistance it has. The length of your blood vessel bed can impact vascular resistance. We said the diameter of a blood vessel can have a huge impact, whether you vasoconstrict or vasodilate. I haven't mentioned this one before, but the elasticity of a vessel can impact this. So, for example, the aorta is, when we're young and healthy, the aorta is very elastic. It can expand and recoil in time with the systolic and diastolic behavior of the heart. And that's great because if I can expand when pressure is high, then I'm not experiencing as much pressure because I've temporarily increased my diameter, right? So I'm not experiencing as much pressure. Think of a person, though, in their 50s who has atherosclerosis, that hardening of the arteries. That directly damages the arteries and reduces elasticity in places like the aorta. So now the aorta cannot expand and recoil as readily as it used to, and as a result, that's going to cause blood pressure overall to be higher. And last one, this one's pretty obvious. If you plug up the lumen of a blood vessel with some occlusion, like a blood clot, for example, that's obviously going to impact resistance. And the more occluded or the more blocked up a blood vessel is, the greater the resistance. This goes back to our discussion on atherosclerosis, and that blood flow is going to be impacted the bigger that atherosclerotic plaque gets. Now, remember before I talked about how arteries tend to have a lumen size that's smaller than comparatively sized veins, and that the veins having a larger diameter assists in the movement of blood? Well, now you can see why. The larger the diameter, the less resistance I have. And if you look at the size of the lumen here of the aorta, 2.5 centimeters, you can see it has a very high velocity, a speed of movement of the blood through it. It also has a lot of resistance. By comparison, if we look down here at the inferior vena cava, it's even larger. They are even larger at 3 centimeters. And that's to facilitate the movement of the blood through that area, because remember, it's at a much lower pressure by the time we're getting back to the right atrium. Okay, let's talk about a few blood pressure characteristics. And actually, you know what? I already more or less talked about this already on the previous slide. I guess I didn't realize I'd already put it in there. So I guess I'll just remind you here again that as we travel away from the heart and out towards the tissues, pressure drops, right? So we have high pressure at the left ventricle, low pressure at the right atrium, and that we have this huge range of values in places like the aorta, but that it smooths out to really no diastolic and systolic pressure changes by the time we get to places like the capillaries and the various veins. Okay, a couple of different terms here I want to talk to you about that relate to blood pressure. If you didn't know it already, there is what's considered sort of the normal value for blood pressure for a typical healthy adult. That typical value is somewhere around 120 systolic over 80 diastolic. And of course, this is millimeters of mercury that we're measuring in here. If a person at rest, and that's the key here, at rest, consistently has a blood pressure that exceeds 140 over 90, that's higher than 140 over 90, we consider them to have hypertension. That means high blood pressure. And there are a number of reasons why having high blood pressure is not good, one of which obviously is the simple fact that the higher the pressure is, the harder the heart has to work in order to move blood through the vasculature. So it puts a lot of strain on the heart because of that high afterload. There are, and this can lead to risks for a number of different conditions. The higher your blood pressure is, the greater your risk of, for example, developing an aneurysm. An aneurysm is when a blood vessel, like an artery, bulges out to the side because of weakening of the blood vessel wall due to the higher blood pressure. Over time, that weakening can become so severe that you actually get a rupture, and those are oftentimes fatal. Another risk that you encounter if you have hypertension, you run the risk of kidney failure because the kidneys have a lot of capillaries in them. Those capillaries are used to filter the blood and form urine. Remember I said capillaries are delicate structures. If blood pressure is high, they can tear and then they scar over and then they no longer function properly. So over time, you can actually damage kidney capillaries to the point where your kidneys can no longer function appropriately and you go into renal failure as a result. What kinds of things can predispose you to having hypertension? Well, being obese, remember. We said that fat tissue has a lot of blood vessels in it, so we're increasing the overall length of the vascular bed. Atherosclerosis, which of course relates to things like having higher than average cholesterol levels in the blood and all the other risk factors we talked about before. Smoking's another big risk factor, and that's because nicotine itself is a vasoconstrictor. So it actually induces your arterioles to constrict when you smoke. The way to treat high blood pressure, number one treatment mechanism is to treat it with diet and hypertensive drugs. On the opposite end of the scale, if a person at rest has a blood pressure value that is below 100 over 60, they are what we call hypotensive, meaning they have low blood pressure. This can be due to maybe they're hemorrhaging, they're losing blood, so their blood volume drops and therefore your blood pressure drops. Maybe they're dehydrated, so their blood volume is lower than normal. Maybe they're anemic. There's a number of different reasons that can lead to hypotension. Good enough. Next up is how we regulate blood pressure.